All right, I think I'm going to get started for those of you in the room. My name is Carina Yang. I'm an associate professor of radiology at the University of Chicago. I read adult and pediatric neuroradiology. So I'm a diagnostic neuroradiologist. I don't do any of the neurointerventional procedures that some of you may have had. I direct the pediatric neuroradiology at U of C. I'm actually the only fellowship, experienced trained pediatric neuroradiologist at University of Chicago. I wanted to thank Dr. Levy and all the organizers for inviting me to come back to speak to all of you, and also thank Dr. David Frim, who is now retired, a renowned pediatric neurosurgeon at University of Chicago, for introducing me to ASAP and to all of you. So my talk is entitled Craniocervical Anatomy in Black and White. And so my talk's going to be a little bit different. I don't have clinic. I don't see patients in clinic as many of our clinicians that you've heard from before do, but I do see you guys in imaging form. I read CAT scans and MRIs in a reading room with a computer. And part of the reason I'm doing this talk is I was recently at a U of C alumni event and met a prominent female judge in Chicago, and she had just had her breast screening mammogram, and she was just asking, what does everyone do in this little circle we were talking. And when I said I was a pediatric neuroradiologist, she just looked at me blankly and had no idea what that meant. She goes, "What do you do on a daily basis?" So she thought that I was actually the person obtaining the imaging, positioning her for the mammogram. I explained that that's a technologist, very valuable to us to have our techs and nurses, but that I actually read the imaging. And she was still more perplexed because she thought that her own doctor, the person that presented her the results or, discussed the results with her, was the person reading the imaging. And so I think you guys are probably all pretty familiar that there are radiologists out there reading your imaging, but for those who are not, we are doctors as well. We're trained to read the imaging and help your neurosurgeons and neurologists care for you. So we will go through a little bit about the anatomy. It's going to be mostly CAT scans and MRIs. So I have a random number. It seems random. Up on the screen. What do you guys think that might be in relation to in terms of the topic I've proposed? What does that number possibly signify? Any ideas? Just shout it out. Bones in the head? Okay. Say again? Oh, that's a good one. I didn't think of that one. Yeah, unfortunately, these days, there's way more than that. I wish there was only 256. What did you say? Colors. Yes, I think she wins. Ding, ding. So it's not so much colors, but shades of black to white, I suppose. So this is us, looking at the computer screen. Basically, it's a grayscale that is the mainstay of all of radiology when we view it on our PACS, which is the Patient Archiving and Communication System. You may have heard your doctor say the word PACS before. So it's our workstation with all the imaging, which is unfortunately way more than 256 images these days. And so this is actually the number of sort of the grayscale maybe 10 years ago when we had a certain number of bits. And so I'll go into how they get to that number. Nowadays, it's actually much higher. Another way to think of it would be shades of gray. That was actually what I was going to entitle my talk. And then my neurosurgeon husband said, no, that's maybe not the best title. They might be thinking they're going to be talking about something else. So he had me change it to black and white, which is probably a wise choice. So yeah, basically each pixel on a digital image has one inherent value that is going to be no intensity, black, to the highest intensity, white. And each pixel is stored with a binary code, 0 or 1, given a value, and is composed back 10 years ago when I started at U of C, 8 bits on those computers at the time. And so the way you calculate it is 2 to the exponent of 8, you get 256. And that's how we get the array of gray. These days, we're actually at 32, sometimes even 64 bits. So the number is way bigger, but I think the limitation now is probably our human eyes cannot detect that many shades of gray. But it's pretty, cool in terms of the technology, which is a big part of our field, how it has advanced. So objectives, by the end of this presentation, you guys, I hope, will be able to list main anatomic components of the craniocervical junction, weigh strengths and weaknesses of CT of the craniocervical junction, and describe cine MR use in evaluating the craniocervical junction. I think you guys have probably seen bits and parts of these throughout the other talks as well. but you'll get the radiologist perspective. So this is a little roadmap I have. You'll see it in the corner of some of my slides, and also some color coding throughout the talk, just to lead you through our journey. So first will be an introduction, and then we're going to talk about CT at the craniocervical junction, a little bit about MRI. We'll go through a case together, and then finally some summary points at the end. For those of you who were in Chicago last year, you may have remembered I attempted the poll everywhere. We had a little slight Wi-Fi and connectivity issue, but I'm hoping it'll go better this time. I think the Wi-Fi signal is quite strong. So to participate, you can either go, there's no downloading of an app, there's no, signing up or anything. You can go to the website, pollev.com/Carina Yen 867. You can text to the 22333 number, my name 867, or the easiest is probably the QR code. You can just scan it. It'll take you straight there. And right now I actually have a test question up, which is activated. So if you guys want to answer the question, what is your favorite memory from this ASAP meeting so far? It's going to be a word cloud, so you can type in your answer to any of that, however you access the site. And I got some music to go with it. Let's see if it's working. This is the problem we had last year. The test question was sluggish, which is sort of weird. Let's see. Let me just make sure it's activated. Yep, it is activated. So it's not going through. This is the problem we had last year. I'm not really sure. I tested it in the room and everything was good. My kids were testing it with me on the pool deck. So it should come up. Let me refresh. I wonder if that's part of the problem. Sometimes it's a little finicky. There we go. It just needed a refresh. So other things, I would have put the zoo if I was playing, but the doctors, the meeting, the people, ricotta. Okay, I like that. Pancakes. Food was very important. Volunteering, support. Excellent. Okay, so we know that it works. So that'll be a few questions further down the line. All right, so in terms of introduction, we're just going to talk a little bit about the anatomy. That's the bony anatomy at the craniocervical junction. I'm just trying to activate the next question. Okay. So of course there's the occiput, which is your skull base with occipital condyles. There's the bones called the atlas and the axis. You guys may know them as C1 and C2. They just have different names. The articulations between them, and then the ligaments, which are a lot of different things that stretch from the base of the skull to the cervical spine, which we obviously want to be well connected and solid. In terms of biomechanics, you've probably learned atlanto-occipital joint gives you 50% of your cervical flexion and extension. And then your atlanto-axial joint gives you 50% cervical rotation. So those are important joints to have. And we'll go through each of these. This is the craniocervical junction. Very busy slide. Don't worry about all the labels, but just to show you how complex the bones and the ligaments are. We'll obviously also touch upon what's in the actual spinal canal and at the foramen magnum. But by the end of the talk, I think you guys will be much more familiar with a lot of these labels and just sort of the overall anatomy. So the bones, first up would be the occipital bone, which is again at the base of the skull. We have occipital condyles, which I'll show you. C1 is also known as atlas. And in case you guys weren't aware, we sort of have that name in our head because Atlas was in Greek mythology, was a titan who was condemned to hold up the weight of the heavens or the sky for eternity. So we think of it as Atlas C1 holding up the weight of the head and of the skull. And then C2 is our axis. So this is a close-up view of the atlas, a pictorial view. This is the entire spine. Now let me get my laser pointer so it's easier for you guys to see. So this is the spine sort of from the side, and you can see all the vertebrae. At the top here is our C1 atlas, which is the one we're concentrating on. This is a look from above, a sky view of the superior aspect of the C1 vertebra, and this is the inferior view from the bottom. And so you see an anterior arch, which is the piece of bone in the front. We have a posterior arch to form the ring. They form from various ossification centers, so you can end up having gaps in the bone, and that's perfectly normal. We see that in a lot of patients as normal variants. We have things that project left and right. These are transverse processes with a hole in it, which is called a transverse foramen. What lives in the hole is your vertebral artery, which is very important. It curves in and out of the transverse foramina to transmit obviously blood up to the brain from your chest area. And then we've got these little blue pads, or they've depicted them as blue pads. These are your lateral masses. And so in the C1 vertebra, you're going to be touching the top of the base of the skull, the occipital condyles. So that's what articulates at this blue pad. From the bottom, there's other blue pads that articulate with the axis, with C2. And so the lateral masses of C1 stick to the lateral masses of C2, which I'll show you in the next picture. A very wide canal at that level with just below the foramen magnum. This is the axis, and this time we're looking at it from the front and to the back. So in the front, C2 is a little bit unusual looking. It's still a ring, but it's got extra pieces. It's got this odontoid process, as you know, that sticks up. In the front here, this blue oval is meant to show where the C1 anterior arch, as on this lateral picture I'm showing you, touches the odontoid process. That's the atlantodental interval, which I'll show you later. On the top here, again, we have the C2 lateral mass, which articulates with C1 lateral mass, which I showed you on the last image. And then on the bottom, there's extra little pads down here. This on the lateral view, you can see would touch C3. So at the C2, C3 level, we then start calling it a facet joint. A facet joint, which many of you may have some degeneration. As we age, we all have facet degeneration, is pretty common. A facet joint is comprised of an inferior articular process of the vertebra above, in this case C2, and the superior articular process of C3. So each facet joint is comprised of two pieces of two separate adjacent vertebrae. This is the view from the back. This oval, blue oval, signifies sort of where the transverse ligament comes across. Again, these blue pads are where the lateral masses are, which articulates with C1 lateral mass. We have the lamina. Some of you may have had laminoplasties or laminectomies. This is the bone that would be removed for that, and this is the spinous process from the back. So next stop would be the joints. We make it easy. We try to name the joints for the two parts that are on either side. So the atlanto-occipital joint is made of the atlas, which is C1 here. This is the lateral mass on each side. We're looking at it from the sort of like a frontal view, a coronal reformative image. And this is the occipital condyle up here. So the atlanto-occipital joint. We then also have a median atlanto-axial joint. So axial, so C1 and C2, median meaning in the middle or closer to the middle. So these are two median atlantoaxial joints. And then we have lateral, further out to the side, atlantoaxial joints. And that's, again, atlas to axis with a joint in the middle. And so in general, I teach my residents and fellows, things are symmetric, look for symmetry. The trick is if the patient's rotated, if you guys are slightly rotated in the scanner, sometimes those joints can be a little asymmetric. So we look at the head positioning where the nose is to account for that. This is a lateral view, sagittal reformative image. So we're looking from the side and it's just in the midline, and you can see the odontoid process, that thing that sticks up in the middle right here in the midline. We have this little piece of bone, which is just that anterior arch of C1, but just a small segment of it. So this is the atlantodental interval, which normally in an adult would be 3 millimeters in size. In a child, it's 5. And patients with Down syndrome or other ligamentous laxity issues, it can be as wide as 7 millimeters. And then we have a posterior arch of C1. Again, it's the back part of the ring, but remember, we're slicing it just as one slice in the middle, so you only see a small part of it. This is your basion and opisthion, which is where I draw my line to evaluate your foramen magnum. You just see a piece of that up there. This is still sagittal view, but we are further out. We are far out to the side now. So you see your occipital condyle and your C1 lateral mass. So this is the atlanto-occipital joint with a characteristic notch in the lateral mass of C1. And then as you further move down, you can see the atlanto-axial joint laterally. So next up is probably the more daunting part. It's the ligaments. And they're not so bad. It looks like there's a lot of lines. I'm not going to go through all of them, but we're going to go through systematically from the front to the back. And it was a nice segue, I think, to have had the talk before you. We just talked about one of the ligaments, so you should know that one already. But starting from the front, we have the anterior atlanto-occipital membrane. So it stretches from the anterior arch of C1. Again, this is a side view, up to the clivus, which is this triangular shaped piece of bone. And this is your basion here. So this is the anterior atlanto-occipital membrane. Next up is the odontoid ligaments. There's two starts with the letter A ligaments. So we've got the apical ligament. That one's easy to remember. It's the one at the apex at the top. So the odontoid process, again, is this little finger-like bone. And we've got an apical ligament stretching from the top of the odontoid process to the base of the clivus at the basion. We have an alar ligament, which is sort of this sling. We've got one on each side going to the medial occipital condyles. I'm now looking at the spine front to back, coronal view, but sort of a little bit further back. So we're behind the odontoid process where the ligaments all live. Next up would be the cruciate ligament, and that's comprised of the thick transverse ligament, which is probably one of the easiest ones to see on MRI, that comes across from one side to the other at the C1 level. And then we've got extensions cranially and caudally, up and down. So up goes to foramen magnum, down to C2, and everything gets connected up really nice and tight. Next up is a tectorial membrane. So tectorial membrane is basically the continuation behind the bones of the posterior longitudinal ligament. So tectorial membrane goes up from the back of the spine up to the back part of the clivus, attaching to the anterior rim of the foramen magnum. And the last would be that one that you just heard about in the last talk about the posterior atlanto-occipital membrane. So the same name as this guy over here, but it's in the back because it connects the posterior arch of C1 up to the foramen magnum where the opisthion is. So those are all the ligaments. So summary of that section is we've got the occiput, the atlas, and the axis with all its articulations, and then all the ligaments we just reviewed. All right, next up is another question you guys can play, participate in. Let me see, where's my music? So hopefully this works. All right. Perfect. So it looks like most of you chose tentorial membrane. Awesome. That is the right answer. So it was a little bit of a trick. It's called tectorial membrane. So you guys have great eyes and great ears. So tectorial membrane is the actual terminology. Tentorium is a real word. I didn't make up a word. It is, you may recognize the dural reflection between the posterior fossa where the cerebellum lives and everything that lives up above. So that is not one of the craniocervical junction ligaments. Everything else is, we talked about transverse ligament, anterior, atlanto-occipital membrane, odontoid ligaments, and the alar ligament. Awesome. All right, next up is CT of the craniocervical junction. And the strengths, what are the strengths of CT? It's a quick exam. Many of you guys have had it, one shot. We usually don't repeat it, but sometimes we do because of motion. It's very quick these days with our scanners. Pretty good resolution, definitely better than X-ray, and safe to use with pretty much all metal implants. There's no downside to the implant, but we do get artifact from it. That means we can't see as well. There's a lot of, streak artifact, and it looks like a starry sky sometimes. That said, you can have metal reduction techniques. So if you are getting scanned and you have instrumentation from a fusion or other device, you can ask them if they have a metal reduction protocol, and they can use that. It does incur other issues, which sometimes creates like a halo, and sometimes I'm not sure if something is real or not, but I can look back at the source imaging to figure that out. And so it is not a deal breaker if you have implants. Weaknesses are you are getting a dose of radiation. These days, the radiation dose is much, much lower than in previous times. That said, we do have low-dose techniques. I wouldn't advise it so much for bone evaluation, but it is fine to use for certain times when evaluating the brain, especially if you're inpatient and you're getting scan after scan. They have low-dose techniques now, and we can see pretty well. There's very little that sort of is subtracted out when we do low-dose techniques. So that's something you can consider asking your radiologist about. Contrast exposure, we don't often give it for spine evaluation, more in the head and neck tumor area that we also read for. But every once in a while you might need contrast, so that's also a possibility. Some people have reactions to the contrast. And then limited assessment of the spinal canal contents and foramina. The only time that the CT can maybe be more helpful is if you get a myelogram. How many of you have had a myelogram? Anyone? Okay. Oh, okay. So good handful. So myelogram is for those of you who aren't familiar, it's a CAT scan that we do, but after we've injected contrast into the lumbar or into the spinal canal. So we do a lumbar puncture like we would normally. We access it, sometimes take out some CSF, put some contrast in, tilt you, all sorts of acrobatics, especially if we're trying to look at craniocervical junction, trying to get the contrast up from your lower back all the way up towards your head. Usually you're positioned like this so that the contrast doesn't end up too much in your head. And then we log roll you a few times, and then we do a CAT scan. And that gives you a relative picture of the cord. You can't see what's in the cord, but it can show the CSF, which is now filled with contrast around the cord, and in some instances, looking for a leak, a CSF leak, which may be concern for some of you, and also syrinxes can fill with the contrast eventually. So those are, things that we can do with CT, but it is an invasive technique where we do have to puncture at the lumbar level. So this is CT of the craniocervical junction. This is a coronal image, again, from front to back on the left side here. You can probably see or recognize a lot of the anatomy we just went through. So this is the odontoid process that sticks up. Here's your lateral masses of C1, of C2. These are the other vertebrae. This is a post-contrast exam. At our center, trauma is the mainstay in South and West Side Chicago, so most of our patients are getting contrast. This is just a special reformat of the cervical spine that I took, but it helps to see the anatomy. So this little line or squiggle here, this is the vertebral artery that has contrast in it. This looks like a bird's beak, or an eagle rather, and the beak is called the jugular tubercle right here. This is the jugular bulb, your jugular vein, the biggest sort of portion of it. So there's blood in here. Underneath the eagle's chin is where my red laser pointer is the hypoglossal canal. It contains a nerve, artery, and vein. Hypoglossal is to your tongue, so it innervates the tongue for movement of your tongue. Let's see what else. You can see a little bit of the vertebral artery, or maybe this is a basilar. There's a vertebral over here. You can even see parts of your temporal bone, which usually is in view when you do a C-spine CT. These little, looks like little nets or lattices. These are your temporal bone areas that have mastoid air cells in them. And you can even see part of the cochlea. This is your inner ear. It looks like a snail on the left side. The patient's slightly tilted, so I don't see it on the right. So that's the coronal view of the craniocervical junction. We've got all our relevant atlanto-occipital, atlanto-axial lateral joint, the median atlanto-axial joint. In the sagittal view, looking from the side, we've got the cervical vertebrae all lined up. I look for alignment of the vertebrae. I look at the vertebral bodies themselves, and then the spaces between them, which, as you guys know, is the disc space. The atlantodental interval, like I showed you on that picture, this is the anterior arch of C1 with the odontoid process, and the atlantodental interval is what I'm measuring. We also measure many other things. There's a Bayesian-Dens interval from the odontoid process to the Bayesian. A lot of these are really important in our high-speed traumas in terms of is there any dislocation or disassociation. And then posteriorly, you can see the posterior elements. This is windowed for bone. So the bone looks really exquisite, looks really nice. What we mean by windowing, which you may have heard, is we pick a value to look at in terms of density, and then we have a level and a window. A window is like plus and minus number of values, and that is what we're concentrating on. So in this case, we're windowing for bone, which means I can't see anything in the soft tissues, not very well. So everything in the spinal canal looks one color. Other things that you can see on this window is air. Air looks very easily seen on bone window. This is the epiglottis, which is that flap of tissue that will hang over when you swallow, and it covers your airway. This is your food pipe here, and it covers your airway so that you don't get food and fluid down your airway. Sometimes you choke. That means something went down this side and not this side. This is the esophagus back here. So some of you have had surgery. You may have difficulty swallowing right after. That's because your food pipe is right behind. This is part of it with air in it. Up here, it's just collapsed at the moment. So this is the epiglottis, and you can see the back of the tongue, back of the nose, back of the throat. This is the uvula, the little pink thing you can see in the back of your throat if you look in the mirror. So you can see a lot of things on bone window, but it definitely doesn't do it justice in terms of the spinal canal and what's in your foramen magnum. I'll get to a soft tissue look at it in 1 second. So this is just a little further out to the side because I want to show you the atlantal occipital joint here. So you can see the occipital condyle with the lateral mass of C1. And then this is C2. You can see C1 and C2, again, lateral atlantal axial joint. This is to the side enough that we can see these little shingles, and the shingles are called, as I showed you before, those little facet joints that we saw. So I'm showing you superior and inferior articulating processes at each level, and they combine to show, to combine to make the facet joints. The vertebral artery is seen. Again, it has contrast in this instance. You normally would not be getting contrast, but it nicely shows it in that transverse foraminal area that basically gives you a bony tunnel for the vertebral artery to run. That's why when you have trauma or when you have a fall, you're at risk for maybe getting a little tear or a little bleeding or a bruise in the wall of the vessel, and that's usually what we're evaluating in a trauma setting. So we're still on bone algorithm, so I can't see much, beyond the bones. That's what shows up best. On the axial view here on the left, we're now slicing like a loaf of bread. We've got the axial image with an anterior arch of C1, the thinner aspect of C1 anteriorly. You see the tip of that odontoid process. So we're right about at this level, just below sort of the pink line that I have drawn here. As we go further down, you can see the odontoid process a little bit better. We've got the lateral masses of C1 coming in, posterior arch, anterior arch coming out of the field of view. Here's your transverse processes with the foramina that the vertebral artery runs through. And now we're even further below that. You have your lamina and your vertebral body with the vertebral artery curving out of the transverse foramen. This on the right here is a sagittal, again, from the side, reformated image, and you can see that I've switched the window. So now it's a soft tissue window, which means I can't see the bones. You see how the bones are all just white now, and it's not very helpful. You can't see what's going on in terms of the bone anatomy. But I can see the soft tissues better. So now I can see the cerebellum up here. I can see the brainstem a little bit. I can see the basilar artery, which has some contrast in it in this case. But you'll notice I can see the cord to some degree. I can't see the intricacies of the cord, and I can see fluid, CSF. So we can see 5 densities on this one image. I can see air, I can see bone, I can see fluid, I can see soft tissue, and I can see fat. So those are the 5 densities, plus we sometimes have metal in terms of an implant or some artifact. If you have a BB stuck in your skin, that would show up as metal. And so those are the main densities we look at on CAT scan. Each one has like a different value that we can actually measure. So in this case, I've drawn the line from the basion to the pision to evaluate the craniocervical junction. You can see the cerebellum here. The tonsil just touches the line, so there's no extension below. It's rounded. Looks like there's enough CSF space grossly. Down here, you'll see that it looks speckled. It looks strange. This is from beam hardening artifact, and that's from the patient's shoulders, usually when they have a thicker, when you guys have a thicker chest, a shorter neck, even, an average shoulder sometimes can cause this. So this is beam hardening. So that really makes it that the spinal canal can't be assessed. Higher up, you can see a little bit better. Down here, I can't tell you what's cord, what's fluid. There could be a hematoma, like a collection of blood hiding. Sometimes we look for, cord morphology. Is it expanded or anything like that? In setting of trauma, sometimes we look for blood also outside the spinal canal in addition to inside, and also acute discs. Some of you may have had acute herniation of discs. Sometimes you can see that pretty well, even just on a non-con CT. In this case, this is beam hardening artifact. The other thing we have to be weary about is streak artifact from dental amalgam. So anyone who's had cavities filled, and especially if you have braces, there's a lot of artifact that comes from that metal, the dental amalgam or the braces. And that usually comes straight across, unfortunately, the craniocervical junction area. You can sometimes offset that by tilting the patient's head up or down. We do that more with head and neck cancers, looking at the tongue. But you can do it for evaluation of the craniocervical junction. Sometimes it offsets the artifact, so it's at a different level, and we get another look at it. CT is also great. You can do it on MRI as well. It's also dynamic, both techniques. Dr. Frim actually used to order a lot of, rotational. We'll rotate the head to one side, image, rotate the other, and image again. You can also do flexion and extension by bumping them up with blankets or pillows. A little bit more limited MRI because of the tube, which we'll talk about. But that can be done sometimes when you have more functional symptoms that are only, provoked with a certain position. It is doable. So summary, strengths and weaknesses of CT technique. We went over sort of the sagittal and coronal assessment of craniocervical junction and the cervical spine, the axial imaging as well, and then soft tissue algorithm and how we use that to look at the soft tissues as opposed to the bone. All right, next question. All right, so we've got here, which of the following can be well assessed by CT at the craniocervical junction? It looks like it's a tie right now, transverse ligament versus bone edema or swelling, and the rest were not as popular. So let's go over that. So the correct answer is actually the joint articulation. So all those joints that I showed you are actually best assessed by CT. The other things you can see some of it, transverse ligament, I showed you on the picture. On CT, it's not well seen. It's sort of a higher density area, but I wouldn't be able to pick out one ligament as opposed to some of the other ones adjacent to it. Cord abnormalities, again, you can see the morphology of the cord a little bit. With myelogram, it would be better seen, but the cord itself, you cannot see inside the cord on CT. Bone edema or swelling, really tough on CT. It's really more of an MRI finding to look for swelling in the bone. You can see fractures well on CT, but the edema that may come with the fracture or other pathology like infection or inflammation is much better seen on MR. And then inflammation, same idea. So. All right. So next up is MRI. Again, some of the strengths, no radiation. So in this case, we can repeat imaging as much as we need to if the patient can tolerate. Very high resolution of the soft tissues. Bone can be a little bit more challenging, as I just mentioned. No known contraindications during pregnancy. It can be done throughout pregnancy. We try to avoid the first trimester because of peak organogenesis. The baby's organs are forming really quick. If really needed, we can still do it. There's no known contraindications. And then we can image repeatedly, as I mentioned. Sometimes patients get really hot and just get uncomfortable from laying there for a long time, so we can give you breaks and bring you back in and re-image. Weaknesses, is it a longer exam? CT is very quick. MRI, probably the shortest is still half an hour for the most part. You have to lay pretty still. So each sequence, as you guys may remember, somewhere in the order of probably at least 4 minutes for most of them, sometimes as long as 8 minutes. So you have to lay pretty still. Which can be a problem for patients in pain, of course. Claustrophobia can be an issue. It is not as wide as a CT. We do have wider bore MRs now that allow for more distance from you and to the inside of the scanner, but some people still feel very trapped inside and can't tolerate the imaging, which is perfectly normal. Some patients will take Ativan or some type of calming agent, and that can help. And some patients really just can't, do not feel comfortable, and that's perfectly fine. It's always, helpful to try, and if you can't, you can't. Some patient sizes are prohibitive. So nowadays, it's not so much the weight. The weight limit, there is a weight limit, but it's usually pretty generous. The girth can be an issue. If your surface of your skin is touching the inside of the scanner, you can get a burn, and I have seen that. We had one in a young teenager, but she was quite overweight, and she had a burn on her arm because I guess my tech wasn't aware that her arm was touching the top of the scanner, so that was a big problem. And then metal implants. Variety of metal implants these days. Most things are perfectly fine for MR scanners. It's all relative. At U of C, we do it in almost everyone who has any type of cardiac implant. We usually have a cardiac fellow sitting next to the scanner to help monitor. If you have a shunt that might need to be reprogrammed after with the magnet, that's perfectly fine. Most implants are allowed, but that's relative because my husband actually works at a larger community hospital next to O'Hare. And his patients, he's frustrated because he always wants to, obtain MRIs, and a lot of them, they won't allow him because they have an implant. I think it's the relative comfort level of the staff, of the physicians there, availability of someone to actually, as a physician, sit next to the scanner to scan, to monitor the scanner and the patient. And so often, he knows that I'm scanning the same patient in my hospital and we have no issues, and he gets really frustrated because he's not allowed to get it. And so if you are at a place where they're saying you can't get it because of this implant or that implant, you can at least try to see if you can go to an academic center. Most likely they'll be able to scan you. So just an FYI. And some metal implants, we need to do like technique modifications. So we might have to only scan you on a 1.5T, the lower magnet scanner. We might have to limit the amount of time that we're scanning whatever portion of the body. There's all these modifications. There's something called MRIsafety.com. It's a public website. We use it. Patients use it. Our techs use it. It's actually a really amazing website that lists every single implant like you could think of, from aneurysm clips to cardiac implant to penile implants. Like everything is listed, and you can look it up as to what safety level it is and what conditions they might have to undergo in order to obtain the scan. And if you have to obtain it at a different Tesla lower magnet strength. Okay, so this is the MRI of the craniocervical junction. This is how I approach it in everyday work. This is a T1 weighted sequence. I'll talk about that in a sec. T2 and a stir. So T1, T2, and stir, what does that mean? Basically, as you know, MRI is a giant scanner rotating our protons, spinning them really, really fast, processing, we say. And so we obtain the values of the different ways that the protons are spinning. We have different values called TR, which is the time to repetition. You don't have to remember that. Time to echo is TE. We manipulate those numbers to give us different pictures, different visual representations of the same anatomy. So a T1, they just call it that, is an image that gives fat brightness and fluid is dark. On T2, fat is bright, but fluid is also bright. And then there's a special one. This is a T2, but it's called STIR. That's short for short tau inversion recovery. That basically is a fluid is bright, but we've made the fat dark. And I'll explain why we need that. So in a T1 weighted sequence, what I'm looking at is the marrow. In terms of your bone marrow signal, the marrow should be brighter than the disc. In this case, I think the patient's actually quite young, so it's almost the same color as the disc. Things that alter the marrow signal can be simple things like anemia, or if you have a smoking history, or if you're young. Younger patients, usually 40 and below, have more red marrow than fat. And so the fattier your marrow is, the brighter your bone will be. Other things that can alter your marrow signal would be not so great things like myeloma, metastases, some type of cancer, lymphoma, leukemia, or you've been treated for cancer. Chemotherapy agents, stem cell transplants can alter the marrow composition. I look a little bit at the craniocervical junction. It gives us the best look at the cortex, that dark margin you're seeing along all the bones here, along all the squares of the vertebrae. That shows up really well on T1. And I'm looking at the fat also behind the spine. The really important fat to look at is this stripe down here that I'm drawing. It's the epidural fat, which is the special space filled with fat that we don't like anything else to live in there except fat and maybe some vessels. Anything else like fluid or blood product is a collection that could potentially push on your spinal canal. So some of you post-op might have had an epidural hematoma or epidural fluid collection. So that's where I'm looking. On T2s, I'm seeing the brainstem and cerebellum morphology much better. You can see it much more clearly. This is a portion of probably the basilar artery coming down here, or maybe a portion of the vertebral artery on one side. We can see, again, we're in the midline here. You can see some of those ligaments we discussed. These are the black lines. I'm not going to go through all of them, but you can see any of the black lines are usually ligaments. The easiest one is usually the ligamentum flavum that you see in the back of the spine. So I'm looking at the CSF, which is bright on here, and the cord, and any abnormal signal in the cord. It should be uniform and sort of like the same as the brain signal. Any bright areas might, including syrinx, could mean that there's pathology there, in addition to things like multiple sclerosis or other reasons that there's brain cord swelling. So I'm looking for the cord morphology. I also look at the discs. As we age, our discs are getting squatter, skinnier, and less fluid filled. These are like cushions, and the cushions deflate. And so the less fluid there is, the disc will have less bright signal will look darker and darker because they literally dry out and the cushions gets not as cushiony. The stir image is just another flavor of T2, but it is a common thing. We get it in pretty much all cervical spines. It's a more sensitive way to look at the marrow signal. So anytime that there's edema, like we mentioned before in that question, in the bone, it will light up like a light bulb, as well as any abnormality in the cord itself. So edema in the cord, in the bone, in the paraspinal soft tissues, it will light up very easily on the stir sequence. I'm just going to show you a sort of compare and contrast of the MRI, which is in the middle here, a T1, a T2 on the right, and this left image is the CT, just to show you the craniocervical junction comparing MRI to CT in terms of the ligaments and sort of the anatomy. You can see this apical ligament. That one is probably easy to remember. You can see it quite well on the sagittal T2 image. It's fuzzy. You can see something there in terms of a density, and that's like a really nice CT. Most CTs they don't necessarily come across as lovely as this. And so the ligaments and other structures are much better seen within this area of fat at the craniocervical junction on MRI. So we don't usually look that closely at the ligaments themselves on CT. Sometimes we'll say that you should get an MRI if we think there's concern for ligamentous abnormality. But you can see how the craniocervical junction in terms of the brainstem and the upper cervical cord, you can see much better on MRI. Again, not meant to evaluate the spinal canal and foramen magnum contents that well. This is a coronal view from the front to the back. This is a little bit further forward with the odontoid process tip. You can see the transverse ligament here coming across the back. Here's our joints, the atlantoaxial joint. Now you have a stripe of bright signal here because there's a little bit of fluid. It's a joint, so sometimes there's a little bit of fluid in there. The atlanto-occipital joint you don't see as well. We're a little bit out of the range of really going right through there. As we go further back, though, this is a further back image where you can see the cord coming in at the bottom. This is the CSF bright signal. You can see the alar ligaments here now and the transverse sort of, the cruciate ligament coming in. And again, here's the atlanto-occipital joint now that you can see. And the lateral atlantoaxial joint is coming into view. So that's the coronal view. This is probably the basilar artery up here just after the vertebral artery is joined. Blood vessels are dark on T2 weighted imaging. Anything that's flowing will be dark. I can't tell you the direction of which way it's flowing, but I can tell you that there's flow. If you end up obstructing a vertebral artery or dissecting it, which means there's a little bit of clot in the wall, that flow void, that dark circle will be not dark, and then I know there's something wrong with the vertebral artery. These are axial images, so again, slicing like a loaf of bread coming down. This black line is not a mistake. It's our text putting a saturation band to reduce the amount of artifact from your swallowing and your throat. Undoubtedly, you're laying there for 4 minutes with, sometimes some secretions pooling. You're going to swallow. That's okay. We have the saturation band that reduces the artifact from that. This is the tip of the cerebellum on the right, a little bit on the left. I think patient's slightly tilted. And you can see here the spinal canal in the back. The patient's nose is over here. Here's the ear on the one side, parotid gland. So you can see the vertebral arteries on the side at the level of the anterior arch of C1 and the cord itself. As we come further down, you can see the odontoid process tip and some of the ligaments that are surrounding it, which is the really black areas, the cord in the CSF and the vertebral arteries. And then as we come further down, you actually see the foramina. So these are actually the CSF spaces that come out to the side that give you room that surround the nerves, where the nerves come out. If you have pinched nerves in your cervical spine, this is where the nerves come off the cord and come out to innervate things, at various levels. And this is the foramen that it goes through. People who have degenerative changes in their spine can end up with bone spurs and discs that stick out and compress that area, reducing spinal canal space as well as the foraminal width. This is more centered at the craniocervical junction. We have sagittal T1 weighted imaging. As you can see here, I've drawn the line from the basion to the epistheon. And so I've got the line drawn, and you can see the tonsils in this person are a little bit low. They're not the most pointed. You can see the morphology better. This is a T2 weighted sequence, so it's fluid sensitive, but it's a special T2 that has super thin sections that give you a lot of cuts, usually just done in the midline. And we can see like the cerebral aqueduct, the fourth ventricle in just better detail, but it does not help with the brain parenchyma or the you can't assess the cord signal on this. It's very not true to what the cord signal or the brain parenchymal signal is. It all sort of looks one shade of gray right now, everything inside the head and the cord itself. So you can see the morphology better and things like adhesions, which we'll talk about, but the parenchyma itself you cannot assess. But you can see the tonsil is pointed a little bit. The CSF space you can see very well is reduced, and so this person is probably having some symptoms of a sort of a mild Chiari. This has been covered in other talks, but this is the CSF flow. I didn't do it as a movie because movies always fail when you're trying to present. So I laid it out, 15 images. This is not the full sequence, but this is the phase contrast technique. So we're doing it, it's still MRI, but we're doing it to see the flow, in this case CSF flow, at the foramen magnum, at the level that's most important in this case. And we're looking for flow in one direction or the other. So flowing in one direction will give you a white signal. Flowing in the other will be dark black. So I can actually tell you the relative direction of flow, using phase contrast. And so if we concentrate on the craniocervical junction, you'll see here there's a white line that continues into the ventral aspect of the cervical spinal canal. And if you follow that anterior to the brainstem and the cord, you'll see that the white line goes away and it becomes dark. And then we don't really see it, and then it comes back, and now we're white again. That shows me that it's biphasic. It's gone, from up to down or down to up. I don't know which is which. Looking in the back of the foramen magnum and spinal canal, we don't see a line. It just looks sort of like the normal shades of gray everywhere else. So there isn't really much flow in the back of the canal and foramen magnum in this patient. So this signifies that there is actually a functional difference from the dorsal and ventral flow. So this is Cine MRI using phase contrast technique. So in summary, we've talked about strengths and weaknesses of MR, looked at T1 versus T2. Now you know a little bit about the labels that we use, and CSF flow and use of sagittal 3D T2. All right, I think I activated the last question. Yes, so the last question is, how is MRI utilized to evaluate Chiari 1 malformation? A, compare post-op appearance of the junction to pre-op, determine morphology positioning of cerebellar tonsils. C is measure the CSF flow velocity across the cerebral aqueduct. D is evaluate the length of any associate syrinx. E is A, B, and D only, and F is all of the above. And in this case, it's actually a preview to the next portion. So if you don't know it, just take a wild guess. All right. Yes, there's always all of the above is always, the popular one, but you guys are close. Okay. So the correct answer actually is A, B, and D only. So C was a little bit tricky. CSF flow velocity, we usually measure across the cerebral aqueduct in patients experiencing normal pressure hydrocephalus. I don't know if anyone has heard of that or has that, but it's usually affecting people in the older, sort of 70 and above age group, and it causes them to have normal pressures when you measure it by LP, but they have hydrocephalus on imaging. And so that CSF flow that we measure at the aqueduct, which is the issue there, to try help stratify who might benefit from surgery or not. In your case, we're concentrating more on the foramen magnum. Okay, so hopefully you guys have learned a lot through the talk. We're going to do a quick case just to go through. This is a 7-year-old boy that was at U of C who had his imaging done. He was young and sort of small, so we did him as an upper and lower portion of the spine. Sometimes we do that. So I've got the craniocervical junction on here, as well as a good portion of his thoracic upper cord as well. And so we have the craniocervical junction. We see if I were to draw my line for the foramen magnum, there's quite a bit of tonsil below, at least 10, probably more millimeters below. It is pointed. Probably better seen on this is the sagittal 3D T2 I mentioned, so you can see the morphology really well. On the right here, you can see the CSF flow. There's flow ventrally with the white line. There's no flow dorsally or very little. You can see the syrinx that has expanded his cord at mid to lower cervical levels. It keeps going into the thoracic. I forget exactly how low it goes. I think the majority of it is on these images. He was then decompressed, and so we again have T1 and T2, the 3D T2. which, as you can see, causes some artifacts, and the CSF flow. And you can see the decompression with the neoforamen magnum. We have more space now around the tonsils. They're no longer pointed. It looks nice and round. We have more CSF space around there. Sometimes you can actually see on the CSF flow or the T2 sequence flow within the syrinx pre-op. And so that's something else we look for. In this case, the syrinx has gotten much, much better. It's much skinnier. There's still something there with a little bit of septation, but it is much improved. And you can see the flow is now present dorsally, maybe not quite as robust as ventrally, but it is present compared to before. On axial imaging, we do 2 sequences. Usually when we image you axial T2, there's also one called a gradient echo, which is the very loud one that makes a lot of clanking sounds. That one we often use more to look at the morphology of the cord itself. So patients with MS, we're looking at plaques to look at the gray matter versus the white matter in the cord. For syrinx, the easier way to measure is usually on T2. So I have the pre-op here and the post-op. Again, like a loaf of bread, I've got the air pipe, windpipe in the front here. Patient's back is on the table. This is the original syrinx. We usually measure it at a certain level, and we measure it again at the same level post-op. I will also measure the craniocaudal length of the syrinx and give either vertebral levels or actual measurement length to give you an assessment of how much it has reduced, hopefully, after surgery. So in summary, we've talked about pre- and post-op evaluation, the morphology of the craniocervical junction itself, the neoforamen magnum, how much CSF I'm seeing at that level, including any adhesions. Adhesions would be like black lines stretching from the back wall of the dura to the tonsils. Sometimes that can cause obstruction of the flow even after surgery. CSF flow itself to look functionally at the flow, and then syrinx evaluation in terms of how much it may be reduced post-op or if it's redeveloped in the future. And then one other thing would be a pseudomeningocele potentially for post-op. Sometimes we get collections of CSF that we don't want that enlarge, and then we alert the surgeons to that. So overall summary, we've talked about the craniocervical junction with all the components, including those tough named ligaments, strengths and weaknesses of CT versus MR technique, and Cine MRI at the foramen magnum. So thanks for your attention. And I think we're doing questions as a panel.